this to post it online. So we have started recording.
Yeah, so, I think that we need to make a library of the slides, and
Yes,
I'm happy.
that's a great idea.
I'm happy to send my slides.
Yeah.
It's like 240 megabytes, so I need to figure out a way to send a big file.
Okay, we'll work that out. You can post it on a Dropbox, and we can access it from there.
Okay. You want me to post it on the Dropbox that we've been working on?
That'll be fun. We have Greg Hartledge is up now. Hello, Greg. Welcome to the meeting, Greg.
Cat's got his tongue.
Greg is mysteriously silent. Although he's been unmuted, he's mysteriously silent. His silence is deafening.
So are we still good there?
We can go ahead and start, and
Okay.
we'll post it for those who got called into the hospital.
So we got a few people on, it sounds like.
We've got 2 staff and 5 attendees at this time.
Okay. So this is a really challenging case. So with the title being TVAD, a ventricular assist device, or not TVAD. So this is a 32-year-old female who was diagnosed with stage 3A breast cancer. I was originally diagnosed in August of 2014 while she was 14 weeks pregnant with twins, who now presents with severe shortness of breath that acutely worsened on March 4th. She was treated at an outside facility initially with mastectomy, actually a radical mastectomy and lymph node dissection in September, then had FAC times 6, and FAC is 5-FU, adriamycin, Cytoxan, through the majority of January 2015. Then she delivered, and as soon as she delivered, she was given trastuzumab and Taxol for 2 cycles, basically through the month of February 2015. She actually delivered 2 healthy twins on January 20th of 2015. So, I mean, just the idea of giving combination chemotherapy with twin pregnancy is quite unusual to begin with. But then giving her trastuzumab immediately after delivery is even more extraordinary.
What's the story about placental transmission of FAC?
Well, there was a recent review that is, I think it was about 100 patients, but where it was safe to give anthracycline-based chemotherapy, but I don't really know if it was combination treatment. It was really just anthracycline-based, primarily for sarcoma, and it seemed to be relatively safe, for the fetus. So this was, that was done in young women because those are the population that have sarcoma. And I think that obviously if you didn't have to give it, I wouldn't give it. But in terms of giving an antibody during pregnancy, that's not really recommended. So that they gave the trastuzumab after she delivered. Her past history was also notable for a pulmonary embolus on CT angio about mid-February. Mid-February of 2015. The details of her breast cancer is that it was considered stage 3A, so she had about a 4-centimeter mass, so she's T3, and then 2 lymph nodes, N2, and she had no evidence of metastatic disease, and that's how she got staged. It was HER2 positive, modestly at 2+, and then ER and PR positive. So her only other past history was her right radical mastectomy, the chemotherapy that I already mentioned. Her EF was 65 before she started her chemotherapy, and then at the end of her 6 cycles, it was 45 in February of 2015. And then, as I mentioned, she delivered twins in the middle of January. She has a total of 4 children. Had not had any particular issues with her prior deliveries. And then, as mentioned, she received 2 cycles of trastuzumab after delivery, followed by 2 cycles of Taxol. So she now presents to us, all of that treatment was done at another facility. And so she presented to us after admission locally for acute shortness of breath. And when she was transferred here, her blood pressure was 98/51, heart rate was 104, respirations were 26. She was afebrile. Her O2 sat was 96%.
Hey, Dan.
Yes.
It's Greg. Good morning.
Good morning.
Greg Bartledge. So at the end of her initial regimen, her EF was 45, and then so that was around the time of her delivery, and then subsequently she received trastuzumab even after a 20-point drop in her EF or so?
Yes, and as a matter of fact, there was a stray BNP done at the beginning of February that was 800. So she had definite evidence of heart failure and LV dysfunction at the end of her FAC.
But it was also at the end of her pregnancy, so that, I guess, should be a little confounding too, huh?
Yeah, I mean, it was, she delivered mid-January. She presented with some shortness of breath in February, beginning of February. That was where the one stray BNP was, and an initial EF after completion of her 6 cycles was 45. And then prior to starting trastuzumab, so there was like a week in there, they repeated the echo, and I'll show you, I have a slide on it, but they repeated the echo is at 50% right before she got one of her 2 doses of trastuzumab. So her physical exam when she presented here, so this is now post-delivery, post-FAC, post-trastuzumab, post-Taxol, now presents with recent history of a PE, shortness of breath. And this was her physical exam. Showed some JVD, 10 to 12 centimeters above the right atrium, 2 crackles and bases. She really had a loud S3. Her PMI was enlarged, and she had a soft holosystolic murmur. She did have trace edema with good pulses. Her labs, the highlights are listed there. Normal sodium, creatinine was 1.33. BUN was normal. Hemoglobin, platelets were okay. Her BNP on presentation here, so beginning of March, was 1181 with a troponin of 0.18, which is mildly abnormal. Troponin I, actually. So there's her EKG. Do we have Zaza on the line? Did you say that, Eric?
Yes, we have Zaza. Joe Carver
Yes.
has
Yes.
joined us. Finette has joined us.
Perfect. Zaza from Israel, what does this EKG look like?
You know, for a younger woman, it's quite pathological ECG. You see a low voltage on her ECG, which should mean some loss of muscle, maybe even pericardial effusion. It's in the differential diagnosis. On the other hand, you see the poor airway progression in her right chest leads and non-specific T-wave changes. So it's pretty pathological ECG for the 34-year-old woman.
Yeah, and the only other thing, it probably doesn't show up very well on the slide that I have there, but, you know, her QT interval is kind of long, so that doesn't help the situation.
Yeah.
But
Maybe
like
she
I
has
said,
somehow prolonged PR, maybe.
yeah. Okay, great. There's her chest X-ray. Greg, you want to comment on the X-ray?
Yeah, so it looks like this is probably a portable film.
Yeah.
And her heart size does look like it may be slightly enlarged. You know, the cardiothoracic ratio, it looks like it's a little more than half. Definitely see sort of prominent pulmonary vasculature, maybe some apiphilization of lung markings suggesting some pulmonary edema. If she's laying in bed, she may have a sort of layering pleural effusion over on the left. It doesn't look like a dense infiltrate. I don't know, am I missing anything else? See her port, or no, she's got a PA catheter in here, so she must be.
She is pretty sick.
One time.
Yeah. Now it, you know, she kind of has some haziness in the vases that may not be all that obvious by this X-ray, and then I think her pulmonary arteries are kind of generous, at least on this X-ray. So, since we're cardiologists, we always do echoes, right? So, Eric, you wanna take the echo?
Sure, I'm looking at left atrium doesn't seem to be enlarged, although on the EKG it could have been. And left ventricle has decreased contractility in this particular film on the upper left, and then you see the mitral regurgitation jet that actually is angulated over to hug the wall and goes to the posterior wall, and it looks like it has a generous origin to it that looks like it's a wide jet. And so those are sort of the hallmarks of what I see here. I'm not sure if that mitral regurg is because of dilatation of the annulus or if there's any pathology. I don't see any underlying pathology to start with.
Yeah, I'll show you some other views, but I don't really think there was any notable pathology on the valve structure itself.
The right side looks okay, I guess. The contractility is hard to imagine on the right side. The right
save your comment
may
on
be
that.
generous. It's hard to tell in this view.
Yeah, I think I heard Joe saying something. Nope.
Okay. If you could make sure that you mute yourselves so we don't hear background noise. Appreciate that, Michelle and Aruna, please. Thank you.
So, Eric, what do you think about these views?
Okay, so now we've got a short axis and we've got a peristernal long axis. And again, you're impressed that the left ventricular contractility has declined further than what we had seen before, and the heart left ventricle has become somewhat generous. Left atrium is also generous, and the right ventricle may be generous as well in terms of its size. And so everything's wrong functionally with this left ventricle.
Yeah, and I think somebody said something.
I was just going to say there seems to be some, this is Emmanuel, it seems to be some flattening of the septum as well. And at least in the person was short, but the loop is really short, so it's hard to make any comments. But
Yeah, no, that's true. And then
in terms of pulmonary hypertension, there's volume overload on the right side.
right. Well, certainly there's evidence of volume overload, and then RV function looks really not so hot. And you see the RV is somewhat dilated, but also quite dysfunctional for a young person. You would think that's distinctly abnormal.
So the heart rate is still up. It's about 99 to 100. And, of course, we know she's had pulmonary emboli, and we don't know what the resolution was of the right side function and pressure after pulmonary emboli.
So what do you think about these images, Eric, since you're doing so well?
And, well, they're very pretty, and, again, show the...
Of course they're pretty. They're right there from Vanderbilt, so they have to be pretty.
Oh, well, I'm not sure about that with the CT and the MRI, but certainly I'll say that the echoes are superb, and my compliments to your team for doing some great echoes. And we've got some TDI over here, and we've got a tachycardia, or at least near tachycardia, 97 to 100, and so there's some merger of the A and the E, making it a little more difficult to say what's happening diastolically. We still got the mitral regurgitation, which is not as impressive in this particular view, and you're more impressed with volume overload and left ventricle dilatation and left ventricular dysfunction and failure. And certainly there's systolic, there's bound to be some diastolic problems as well, especially with volume overload.
Yeah, I think, can you guys see my screen? Do you see my little hand?
Yes, we do. And the next thing, there doesn't seem to be any pericardial fusion, so we're going to get by that one for sure, if there is a trace.
So if the E prime is really small there, and then you see here the variation in the E velocity over the course of about 10 beats. That's probably a pretty strong sign that this is, really severe heart failure, and you're having ventricular interdependence.
Hey, Dan.
Yes.
Do you see that happen when you have sort of acute dilation of the heart to the limits of the pericardium, even without a pericardial effusion, but in these kind of acute enlargement type of states, like you might see in a myocarditis or something like that, even because even on the previous short axis image, it looked like the septal flattening was sort of respiraphasic too.
Yeah, that's true. That's exactly right. And so, if you just show a Doppler profile of the mitral valve inflow and you see this respiratory variation, your first thought is that this, could be tamponade. So as Eric already pointed out, she doesn't really have much of an effusion. But the physiology of variation of inflow based on respiration is really what it's showing you is ventricular interdependence. And so in the case of severe LV dysfunction, the physiology is the same as with tamponade, where, as you just said, Greg, the pressures or the volume is stretching the limits of this pericardium and making it such that if there's some more inflow in the left, there's less inflow in the right, and vice versa.
And do you feel that you can read someone into the acuteness of this
You know, if it was more of a chronic process, do you think that the pericardium would have stretched and you wouldn't see this?
I don't know. That one's really hard, but what I would say is that this definitely belies severity. So I think that, you know, this is severe. This is as bad as it gets hemodynamically. So she had various EF measurements over time, and I listed those on this slide. So in September, before she started all her chemo, her EF was normal. At the end of her FAC, it was a little bit depressed by a report. You know, we didn't have any of these images. And then that was right at about the time of delivery. And then shortly thereafter, they planned to give her trastuzumab, so they repeated the echo, and the EF was exactly 50, according to their report. She got 2 cycles, 2 doses of trastuzumab and 2 doses of Taxol. This is a really strange regimen. I don't know if Susan or somebody, some oncology person is on the line, could comment about the regimen that was chosen. But anyway, be that as it may, you see at baseline prior to the trastuzumab, her EF was just barely normal, and then probably you would say that her LV had dilated or something like that, so I suspect that that's not really a normal echo. And then her EF, when she presented here initially, was 15 to 20%, and then we repeated it a week or 2 later, and it's, you know, it's less than 20, EF about 10. She had a right heart cath during her, you know, admission here. As Greg commented on the chest X-ray, the swan was in place. So here's what we found. Right atrial pressure was 14, RV was 35 over 12. Her PA pressure was 41 over 23 with a mean of 32. Her wedge tracing, she had a mean wedge of 22 with a V wave up to 28. Her PA sat was 52%. And then our cardiac index by thermoevolution was 1.85, or by thick was 1.65.
Dan, we're more reluctant nowadays to use the SWAN in the ICU because of some of the reported data of complications and so forth. What do you think the SWAN adds anything to this particular case?
The actual measurement, in my opinion, adds greatly. But, you know, leaving it in the ICU, I would be interested to see what Emmanuel has to say about this. But most of my partners, so the people that I work most directly with in the heart failure world, are all dealing with pre-transplant, post-VAD, et cetera, so they're the sickest of the sick. And they are inclined to admit people to the ICU and leave a SWAN in. I am personally not inclined to do that, and so I very rarely do. But I think actually measuring the pressures and the cardiac index is a critical step in determining what to do.
Yeah, I think I would be, I personally am more SWAN friendly. I like hemodynamics, I like data, and think how things changes. The reports have been in which SWANs are not, you know, they had bad outcomes. There actually are those patients in which investigators were equipoised whether to put a SWAN or not to put a SWAN to begin with. Like, for example, take the SCAPE trial, or in the the trials in the ICU in the past. There were also there were never patients on cardiogenic shock, in which we randomized whether to put a SWAN or not. In terms of advanced therapies, is also important, right? Because you have some hemodynamic criteria that is predictive of how the right ventricle is going to do if you're thinking of VADs, for example. So based on the RV stroke work index or the right atrium to wedge ratio, there's some predictive data that is taken from a swan that you can have. And on top of that, you can see how, if you put a balloon pump, or if you put inotropes or nipride or whatever you're treating to treat the heart failure and top of that diuresis, I guess the goal would be to normalize hemodynamics and see how they do. But each center is different based on their culture.
Yeah, so I mean, I think Vanderbilt is similar in that you can't, it'd be hard to find a standard operating procedure, and everybody has their opinions. So I think that especially for the advanced heart failure team, they use SWAN data quite frequently. Like I said, I'm very much in favor of the data, but I don't like to leave them in just because they're frequently associated with complications. So anyway, that was her numbers. This Emmanuel, what would you say about these numbers? Yeah.
They look bad. It looks like she's in cardiogenic shock and has an elevated right ventricle and left ventricle filling pressures.
Her PVR was 2.5 Wood units.
Yeah, that's actually, I think, it's probably less concerning to me because I think that PVR is driven by the low cardiac index. But if you see the transpulmonary gradient, it's actually not that elevated, which is all arguing in favor of this acute presentation, not something has been lingering for a long time and causing some pulmonary remodeling. So that PVR, I think, can be easily normalized by correcting the index. So I think at first, I think it's obviously she probably needs some diuresis. It's not calculated here, but I assume that if her, do you know what her systemic blood pressure is, or was at that time?
It's about 95.
It would seem then that her SVR is probably around 20 Woods, or it's probably elevated.
Yeah, I think it was 22.
Mm-hmm. So I guess the usual thing here would be to open up the flood plates and giving her some aggressive afterload reduction and diuresis, and think with that only that index may improve, and you may or may not want to put inotropes on it. I think options like either some loop diuretic and either a balloon pump or inotropes or just nipride based on the center will be a good next approach.
Yeah, excellent. So, yeah, she was given diuresis, and they actually did add milrinone. Her blood pressure was kind of borderline, but she was able to tolerate that. And there was some improvement, not dramatic, but some improvement. So what do we do now? What do we do with all this information? So we got severe LV dysfunction. We have recent chemotherapy, recent pregnancy, hemodynamics that don't look so good, and the RV function, which doesn't look so good either. So in terms of strategies, what would the crowd vote for? Do we try to clean up her meds if possible? Do we add inotropes? Do we go straight to LVAD? Do we wait for improvement? What do people have to say about that?
I think, in my opinion, the best approach would be always to get her out of cardiogenic shock and make sure her end organ function normalizes. So as I said, you can do that however you want to, different strategies, but I think it has to include a combination of diuresis and either afterload reduction and plus minus something to, in some inotropism or something to improve cardiac output of contractility, either with a balloon pump or inotropes or things like that. Once that happens, it's always a good thing to try to optimize oral therapy subsequently to improve her afterload reduction. So, for example, you can diurese her and make her euvolemic with, say, I don't know, loop diuretics and dobutamine or milrinone. And once that is, then we can always optimize her oral medical therapy as we wean the inotrope down and have her ambulate and walk around and make sure her in-organ function remains stable. And then the other things,
So
then I would say that LVAD, RVAD, all these other things are probably, there would be the following step after initial stabilization, unless she has refractory cardiogenic shock, and then that would be another, another situation.
So, Eric, didn't you tell me that Michelle was on the line?
Yes, sir. She is on the line. Michelle?
Yeah, does she have a thought about this?
She is alive and unmuted and ready to go, but we don't hear from her.
Okay. Maybe she hasn't figured out her microphone issues. Is Joe still on the line?
Zaza has raised his hand.
Yes,
Okay.
yes. I want to
Zaza,
ask
what
you,
do you think?
what's about? Yeah, I will wait with any instrumental support at least for 24 hours. I mean, I will optimize her medical treatment by giving her inotropes like milrinone, even with combination with some noradrenaline if its blood pressure goes down because of milrinone. And on the other hand, to diurese her very aggressively and to take her right atrial pressure down at least to 10, something like this, and to begin really aggressive vasodilator therapy. Vasodilator by ACE inhibitors. You didn't mention, is she black woman or white woman?
No, Caucasian.
Okay, Caucasian. So probably ACE inhibitors will be a good choice if we can very carefully build the therapy under the inotropic support, in very, very, very low doses. But maybe the first step should be some combination of inotropes with nitrate, and to see where she goes. And if she stabilizes during 24 hours, probably you will go further by oral therapy. And if not, sure, LVAD is a good option.
So, does anybody feel like they need any other tests?
Well, hey, Dan, I don't know about other tests right now, but I do have a question. Is she felt in general to be in remission right now from a cancer standpoint?
It's hard to know. So she had no evidence of metastatic disease
Right.
at baseline. She had a 4-millimeter non-calcified nodule in one of her lung fields.
Yeah.
That was not evident by PET imaging prior to all this, and repeat CT here showed a 4-millimeter nodule that hadn't changed from the report several months ago.
Right.
So,
I mean,
so
so
no.
just thinking candidacy for LVAD, I mean, obviously she wouldn't be a transplant candidate right now, given how close she is from her cancer diagnosis and treatment. I don't know how your surgeons are there with LVAD. If she was thought to have active cancer, I think that would be an issue, but it sounds like she's not. And then the other question, I guess, would be, I guess she was on trastuzumab when this happened, and how far into her trastuzumab therapy, and how much perhaps reversibility could there be with this? Would you be thinking if you did LVAD, potential destination LVAD, or until she is a transplant candidate, or would she be somebody, if she was on trastuzumab when this all happened, that maybe would be one of these more bridge to recovery types situations, maybe?
Yeah, so she got 2 doses of trastuzumab. So that's all she got. So, in terms of her cancer prognosis, she's probably got, at this moment, she's probably got an 80% chance of surviving at least 5 years. But one of the things that you don't know about this is that she got the majority of her treatment. So you could have extended that survival just based on her cancer because of the treatment she's already got now. So we don't really know about that. But So she's got at least an 80% 5-year survival rate, just based on what we know. So because we're cardiologists and we love imaging, we felt like we needed more information. And Eric, I'm surprised you didn't say anything about an MRI. I mean, come on.
Well, we do love imaging and we love MRIs. And so the MRI can be very helpful in patients that you suspect some mitral regurgitation, because frequently it's the same information that you get on the echo but superior. And there's a recent study that showed that MRI was better than echo for estimating the severity of mitral regurgitation. And on our patients that get mitral valve repair, it seems to be equivalent to the TEE. And so anyway, this is a study that shows her left ventricular and right ventricular impairment, as well as what appears to be some dilatation. And you see her left and right atrium pretty well, and you can't really see the mitral jet in this particular view, but I'm sure there are other views. And you can see the pericardium, and that it's not compromised by tumor or by fluid. And so it's a very pretty study. And I love looking at MRIs, so I appreciate it. You can also see her breast tissue, and I'm sure someone with some knowledge might be able to tell us more about that too.
Yeah, well, she only got one of them, but so the measurements were an RVEF of 32%, an LVEF of 21%, and that was felt to be mild mitral regurgitation. And then here's some more images.
Then
Yes.
I just had a quick question. So this was after she was stabilized, or was she was still and under with inotropes? So what happened after the initial?
This was immediately before inotropes. So she had had a presentation for worsening shortness of breath and had been treated with diuretics and that sort of thing. Mm-hmm. And they were contemplating whether she was going to need some more advanced therapy, and so we got the MRI right before that. Okay.
So how did she do after she had the swan? Would you be able to normalize hemodynamic with therapy, or? Because I think much of the therapy will be depending on that. Especially, her RV looks not very happy here, but there's no significant, all the data that you have a predictor of how the RV is going to do, if we're considering LVAD is actually hemodynamics. So you want to have a right atrial pressure of a wedge that is less than 0.63, and you have a stroke, RV work index that is also around 300. So.
Yeah. So. Eric, do you have any further comment about these MRI images?
Pretty much the same here, and the short axis at the papillary muscle level, and the other are not. They're confirmatory, but no new news.
Well, their gadolinium image on the bottom there showed no gadolinium uptake. I don't know if that's significant, but it seems like it's probably significant.
And we didn't expect there to be gadolinium, and didn't expect scar anyway.
Dan, can you guys hear me now?
Yeah.
Okay, sorry about that. I'm having technical issues because I'm calling in from home.
Oh, okay, no problem.
Sorry about that.
Yeah, so, I think that the MRI I felt like it was a useful negative test, in that, so right now we have at least 3 reasons for severe LV dysfunction, and I'm not sure which one is which. And then I wanted to make sure that there wasn't any scar tissue or evidence of myocarditis. Not that we need to find another condition, but if that had been the explanation for her sudden decompensation, then it would have been important to know that. So that was what I felt like was an important step in the evaluation of this patient. So right now you have anthracycline, trastuzumab, and then postpartum as all as potential explanations for her LV dysfunction. So I did want to just talk about the chemotherapy piece a little bit. So in the major trastuzumab trials, when a person got all the drugs, they had the most impact on their cancer treatment. So this is one of the seminal publications a few years back showing that when they got ACT plus trastuzumab, the breast cancer recurrence was by far lower than the situations where they didn't get all the drugs. However, there was, a significant increase in those people who had grade 3 or 4 heart failure, which in this case clearly is, would be CTC grade 4 heart failure. And if you look at the table on the bottom, it's about 2% of patients who got all the drugs had severe heart failure, and about almost 20% had significant EF change. But in this case, she fits in severe heart failure. And from our friends in Italy, Daniela's data showing that if you identify LV dysfunction early, even related to anthracycline, and you initiate appropriate heart failure therapy, then the chance of improvement back to normal is quite significant. So that sort of goes against the dogma that's out there that anthracycline-related toxicity is permanent. This data would say otherwise if you clearly identify it early. So that doesn't mean it always improves, but that a significant portion, if you identify it within the first couple of months, will return back to normal. Now, the problem here is that this is really severe LV dysfunction. So, we've clearly gone past, just mild or moderate LV dysfunction. Now we're in cardiogenic shock, as Emmanuel said. And then we published some experience with trastuzumab that, you can have evidence of significant LV dysfunction during trastuzumab therapy, and if you initiated heart failure, appropriate heart failure medications, the EF would potentially improve back to normal. And then if you look at the last panel, a number of those patients were able to be put back on trastuzumab and stayed on heart failure therapy and were able to take trastuzumab for an extended period of time. This is a concept that most people are comfortable with now. However, I would say that, there's still data out there that not all trastuzumab-related toxicity is reversible. And this is one paper showing that a significant number of patients don't actually recover, and they continue to have significant LV dysfunction even greater than 6 months after a diagnosis of toxicity. So the dogma that anthracycline is permanent is not really true. That's one thing. And then the general belief that trastuzumab is reversible is not always true either. So I think that we don't know as much as we think we know about these particular drugs. And then Carrie Lenneman published a paper. She's at Louisville, and sometimes she's on our webinar, looking at the UNOS database. And as it turns out, there's a rising incidence of patients that get transplanted that have chemotherapy as a background or as a reason for their LV dysfunction. You can see here over the last 25 years, there's a rising incidence of patients that have that in their history and end up on the transplant list. And then, more importantly, their outcomes are basically the same. So I think that this was a very important sort of review showing that, especially in patients that have chemotherapy-related cardiomyopathy, that you can treat them, like we would any other patient that has cardiomyopathy problem, and they can do well. So, what about this patient, Emmanuel? To your suggestion that we, sort of optimize therapy and then see what happens. So when she originally presented and we had all the tests, et cetera, that we went over and did the right heart cath, there was a discussion, a very extensive discussion here at Vanderbilt whether to do an LVAD, right then, and to go ahead and support her because she was sort of in chronic cardiogenic shock. There was a lot of discussion about that strategy, and then the idea is that she potentially had a significant chance of recovery. Whether we decided that this was anthracycline related or trastuzumab related or even postpartum related, all three of those have potential for significant recovery. So we thought if we could just stabilize her and sort of manage things optimally, that she may show some sign of improvement. So that was the general plan about 2 weeks ago. And then over this past 2 weeks, she's been on IV milrinone, Lasix, and low dose of toprol and ACE inhibitor. Her liver enzymes went up fairly significantly. Her BNP stayed over 2,000 for a 2-week period, and then her creatinine had gone down to below 1, and a couple of days ago it was 1.33. So we felt like there was evidence that her end organs were suffering. So she was readmitted, and she's currently in the ICU, and actually there's a plan for an LVAD tomorrow.
Dan, was there any thought in your center about something like an Impella, which we sometimes use that approach when we really don't want to VAD them because we're concerned about sort of long-term toxicity with VAD, and in this patient I'd be concerned about thromboembolic events, etc. Whether you could stabilize them with something other than inotropes, but something in between inotropes and permanent LVAD.
Well, I can't speak for everybody's opinion on this, but at least my general observations for the Impellas is that they just make the situation worse. And frequently we have, especially in somebody who's had a recent PE, we have just disastrous hematologic problems whenever you put in an Impella. Emmanuel, would you have a comment on that?
Yeah, so I think, we sometimes use Impellas, but I see Impellas as a fancy balloon pump. They're usually bridged to something durable. So they don't have any data in terms of outcomes or survival if the patient has to be hospitalized. So I think, if you, depends on what Impella do you have. If you have a 2.5 or a 3.2 or a 5, but it's like a powerful balloon pump that you can put prior to put somebody on ECMO if you need to, or but obviously different centers they use it differently. I guess my question about this, I think the data that what you mentioned before about sending her home on milrinone, I agree that's probably what I would have done as well, trying to stabilize, see if she recovers. Interesting, however, all the data that you have on recovery, it's not on patients that are on inotropes. right, there are patients that are in chronic heart failure, and you can optimize med medications, even postpartum cardiomyopathy or all the other data that you have published. And now patients that are nanotropes per se, at least there's not data necessarily on that. Something that I thought interesting is that she was discharged on milrinone and toprolexel. And I know some centers do that, and as you know, her intracellular molecular pathways of milrinone and beta blockers are the same. So even though they activate different receptors on the surface, when you come to the actual myocyte machinery, they actually intersect. So I wonder, first of all, if she couldn't have full milrinone effect because she was acting on toprol, and again, I don't know what degree of, how much milrinone she was on. And then how about her
0.375. Yeah, I actually agree totally with that. I can say that I didn't make those medication choices. So,
and it would be interesting to know when she came back, what were her actual hemodynamics? I mean, was she still in shock, in cardiogenic shock, because she was on beta blockers?
I don't know that. I don't know if she had a right heart cath yet.
Because that would be interesting to know. Well, is all her end organ dysfunction? The most likely thing would be to believe that her end organ dysfunction will due to her hemodynamic, abnormalities. And if that would be the case, that's probably what I would do rather than put her to bed right away, because she only had about a month wait time.
Yeah, it's really only been about 2 weeks.
So it's actually really, if you're thinking about recovery, it's probably not enough time.
And then a couple of other details. I don't think we have an oncologist on the line today, but there's a couple of sort of strategy points that I would say we really could have made a difference in this patient. I think if we had provided some input earlier in the course of these decisions. So first off would be, I think we were already seeing signs of LV dysfunction as she was going along in her anthracycline treatment. And, she had a BNP that was 800 back in January. She had already taken a hit. So she needed to be on appropriate therapy at that point, for sure. And then the second is that the timing of giving trastuzumab after anthracyclines, the HERA trial and several other international trials waited more than 90 days, actually up to 180 days, before giving trastuzumab after anthracycline. So the fact that they didn't wait any time whatsoever, to me, is crazy. I cannot believe they did that. But anyway, so I think that if I had been engaged in this patient's choices back in January, I would have said, wait a minute here, we need to make sure we got her heart failure under control. That's one thing. And the second would have been delay her trastuzumab treatment for a while, at least a couple, 3 months.
Sure.
And then, and there's no cost to this patient in the long run if you delay even up to 6 months for initiating the trastuzumab, especially if you actually get the trastuzumab over the course of the next year. In this case, she's not going to get trastuzumab anytime soon.
Sure. So I think in terms of this, what I would personally do, if she would come with this drugs and milrinone and still in signs of an organ dysfunction, I think I will bring her directly to the cath lab. I'll put a swan in, as we talked before. I'll measure hemodynamics. If her index is low and she's volume overloaded, I will stop the toprol and increase the milrinone to 0.5. And after the research, see if I can actually normalize her hemodynamics with an index above 2 and resolve her end organ dysfunction acutely. And then after that, I'll just, walk her around and see if she can actually, that's fine. And then, if possible, I think I would wait as much as I can before implanting the VAD. However, if with that medication I cannot achieve, and again, you can maximize her ACE inhibitors, you can add hydralazine imidazole, you can even start digoxin in order to improve a little bit her contractility and afterload her as much as you can, and you can make calculations from the SVR, and you can do a swan-directed therapy sort of to normalize all the parameters. And then if with all this you cannot in the hospital normalize hemodynamics, then I really cannot see any other way than putting a VAD on to get her out of the hospital. However, most patients, the vast majority of patients, I think, you can normalize this. Now, another thought, like I mentioned before, if you have a swan end and you have a milrinone and you really cannot get that CVP to wedge ratio less than 0.63, and the RV stroke volume is low, the actual chances you're going to not need an RVAD are much higher. And as you know, there's really no RVAD approval out there that is actually FDA approved. So she will need to go through insurance and have to do some sort of compassionate use to do that, because if not, you're going to end up with an LVAD on the left and a centromag on the right, and the chest open after that happens. It's just going to get chaotic. Yeah. Another option would be to. Oh, I'm sorry. Go ahead.
So especially since her right side of her chest had the radical mastectomy, it's not totally normal.
Yeah. Another option would be, if you cannot normalize their right ventricular function or the right ventricular function, consider a total artificial heart. However, her chest has to be a particular size. And another problem is currently approval for bridge to transplant. So if she cannot be listed for transplantation, as we talked about it, that she can't, then that will not be an option. So really, you're only
so I really think that I think there should be consideration to listing her for transplant. But
may I ask a question?
Yes.
Zaza? Does anybody consider ECMO in this patient for making her sure for at least 1 week to she recovers, or any kind of temporary VAD support like Centrimag, Levitronics device, to let her to improve?
Yeah, we usually do use them frequently. However, as I said, they're the same as a balloon pump or the same as an impeller, usually bridged to something. ECMO carries, I don't know in Israel, but over here I think it's about a 10% stroke risk a week if it's centrally cannulated. If it's peripheral ECMO.
Peripheral ECMO, yes, for about a week.
Yeah, if it's peripheral ECMO, then I guess the risk you go in this because her ventricle is very dilated. So you would actually never completely decongest the LV, and you have more problems.
We use it in combination with balloon pump. We combine it with balloon pump.
Yeah, so
that was temporarily discussed here, that they felt because of that. She wasn't sort of actively decompensating. So
yeah, but that could definitely be a possibility. I mean, if you're really thinking about, if you have VAD approval and you're really going for a VAD, you can obviously do either peripheral cannulator or a central cannulator with an LV vent if we are suspicious. But again, I'm not really sure if it all depends what her SWAN numbers are and what her, how much you can recover with the simpler stuff first. But it is definitely a possibility.
Well, great comments, everybody. Thanks for joining. I did want to share this one image. Dr. Herman at Mayo Clinic asked me if I had ever seen this before, and I can't say that I did. So, Eric, this is an MRI.
Dan. Obviously, this is a different lady because she has both breasts intact, and there's a pericardial appeared density there, and the pericardium seems to be the pericardium, and it seems to be intact, and it seems to have a density in it, and it seems to have also some homogeneous finding of perhaps some fluid in there. And
yeah, it was read as fat.
Yeah, I see the fat. I was looking over here and looking at the breast, and if you compare the breast density to the pericardial density, you'll see it's the same. And so most of the breasts consist of fat, and so that's a lot of fat. And then there's that other area there that I don't know what to say about it that's in there. So
this is actually a CT scan looks like, and it's a contrast-enhanced CT scan, and it looks like we are here. We have an arterial phase image where the LV and the aorta are lit up essentially, and then there's this area in the in this fat in the pericardium that also lights up, suggesting vascularity. The other thing is that it could be calcification, but it looks more to me to likely be a hypervascular component of this very fat kind of looking thing that even appears to be extending into the right ventricle. And you can see that this contrast isn't coming from the right ventricle, because the right ventricle is the venous phase, and it's not as enhancing as much as the arterial phase.
Yeah, it's weird. I don't really know what this is, and so and I can't say I've ever seen this type of thing before. So the general suggestion would be is that you probably need to do some biopsy of it. that was kind of the final analysis, but yeah. So there you go.
The final analysis was what? What did they say?
The final analysis was that it was fat, a large collection of fat in the pericardium that extends into the RV, and some evidence of vascularity, as you said, and we didn't know what to do with that. And so you always, it seems to me, you always need to make sure it's not a sarcomatous process.
Yeah. Interesting.
I mean, but, you know, if you have some other suggestion, I'm sure that would be an important thing. So then the only other thing I would remind all the people on the call is that we're having a Global Cardio-Oncology Summit in Nashville in October, and we certainly expect everybody will come. Nashville's a great place to be. So, all righty. Thanks a lot.
Thanks so much, Dan. Great presentation, great cases, and the last one.
Yeah, I think we have one in May. I guess the second Thursday in May.
Yes, maybe we can invite the folks that were involved in that patient's early care to our cardio-oncology conference for engagement.
That would be good. I will try to do that.
Thank you so much.
All right. Thanks a lot, guys.
Thanks. Bye-bye.